Thank you.
Thanks, Ms. Edelman. Thank you all for your testimony. Ms. Duchendorf and Dr. Sheehy, do you think, your view, do RACs disproportionately target high-value inpatient claims?
Yes.
Yes.
In the appeals of those, could you give us what you think is the true cost of an appeal? My assumption is high-value claims are more complex. There's more of the file to review. You're obviously bringing in medical professionals as well as the appeals process. In a case like that, for a hospital, what's the true cost of that appeal, roughly? I'm sure it varies, but...
So we actually, when RAC was proposed several years ago as a permanent part of the program, we actually went through a process to estimate the cost of an individual appeal. You have to add into that all of the costs associated with the medical record requests, the issues in terms of loading this into software because of the mountain, and for a hospital like Hopkins, it could be 600. And then you've got 50% of those that may be denied, so then the tracking and everything that goes along with that. So there is all of that prior work. Then there is the estimation of time it is for our nurses to review the cases, our physicians to review the cases.
What do you think that cost is overall?
So we estimated it was about $2,000 an appeal at the first and second level. But then when you get up to the ALJ level, that requires another add-on because you need attorney support with that as well as physician advisor support during that time.
What do you think that cost is?
I could probably get back to you, but I would say it's a couple of $1,000s per at the ALJ level.
In addition?
In addition to.
After the first two steps,
Yes.
the third step?
We actually, we as a health system spent about $4 million just gearing up for the RAC process to add on the additional personnel it would take to manage that process.
Was that compliance and appeal?
Compliance, appeals, and medical records, and just managing and tracking the whole process as well as software.
Thank you. Dr. Shee, do you have an estimate on the cost of an appeal on a high-value claim?
Yeah, I don't have an estimate on a single appeal, but I can say the resources our hospital puts forth in the whole auditing process. We have multiple nurse case managers that their entire job is to determine status and assist physicians in helping to determine the proper status. Once an appeal is made, we have a team of lawyers, our CMO, 2 utilization review physicians, and multiple other nurse case manager staff whose job is to fight the appeals process. So anyone looking at those numbers of staff can calculate that this is a costly endeavor to our hospital.
Okay. Did both of you hear Mr. Kavanaugh describe one solution, a short stay outlier approach? Do you have a view on whether that helps, hurts, doesn't solve the problem?
I think, you know, when we've been talking about different solutions, and obviously I think CMS did intend the 2-midnight rule to fix a problem in observation status. They recognized that there were issues with the current observation policy. I think now we've seen that the 2-minute rule also has issues, and we would hope that there would be more consideration of policies going forward, thinking about the true definition of what observation truly means. A very short stay, a patient, a very well-defined subset of clinical needs prior to going forward and coming up with a new plan. We would also strongly advocate for a pilot. I think with the 2-midnight rule is evidence of rolling out a policy across the country with unintended consequences. I think a pilot would be of great benefit.
I would agree with that, with everything Dr. Shee said. One of the statements that was made earlier is that there was disparity between the cost of observation stays. And I would submit that one of the reasons for that is the true definition of what observation used to be, and that was a period of time to help determine whether or not the patient needed hospitalization as an inpatient or could be sent home. Those short stays in observation would be very less costly. By the time they need to be admitted, those are patients that require extensive diagnostic studies and intensive treatment. And sometimes those patients turn around in less than 2 days. And so we should not be penalized for being efficient in our ability to manage those patients as an inpatient.
Thank you. Ms. Edelman, you made a point that drew my attention. You were making the case that if outpatients return to the hospitals within 30 days, their return isn't a readmission because they were originally labeled as outpatient. And some portion of the reported decline in hospital readmissions reflects the fact that many patients are called outpatients. Any idea how frequent that is? What percentage of the reported decline that might represent?
We don't have data that would indicate what portion of the readmitted patients are not called readmitted because of observation. But actually, the only reason that we have ever heard from families told by the hospitals that they are using observation status is the recovery audit program. Nobody has ever actually brought up the hospital readmissions issue, but we know that that is now in effect, and so it obviously has some impact. Because if somebody returns to the hospital as an outpatient, that does not count as an inpatient, and it's not a penalty, would not be applied.
Dr. Evans, when there are costs associated with the hospital appealing, especially in high-value inpatient claims, and they are overturned, the RAC returns the commission. Is that correct?
That's correct.
Do they share in the cost of that appeal at all?
Well, the cost of our work doing that appeal and the work doing the review initially.
But having lost that claim, do you share, does the RAC reimburse some portion of the cost?
Well, we're paying back all of the funds that were used
Right.
on our part to do the work.
Because it was an improper determination up front, but do you share in the cost? So you don't receive your commission. Do you share in the cost
That's
of the
financial
appeal?
penalty that occurs.
What,
That's the
in
financial
addition to the-
penalty that occurs. There's not a payment for any of the costs of the hospital.
so
I'm not aware of the...
the impact is you return the commission, but you
Yes.
don't share in the cost of the lost appeal.
We pay our portion of attending the appeal, and the provider pays their portion of
Say
attending.
that again.
We pay our portion of attending the appeal, and the provider pays their portion of attending the appeal.
Okay. Win or lose, that's how it's divided.
That's correct.
Okay.
So when we win, there's not any difference either.
Okay. And I'll finish with this. Listening to testimony today, there are an isolated number of short-stay DRGs that may be problematic. It was discussed earlier. In the oversight of the RAC program, did CMS ever intervene to stop audits so they could insert a targeted payment approach to quickly and easily solve the problem of these short-stay DRGs?
And you said a targeted DRG approach?
Yeah.
They haven't intervened. The intervention has been to stop the short stay reviews with the 2 midnight rule, but there's not been an intervention. And I think what we've heard said today is there's a lot of variety, a lot of difference across providers in the rate of improper payment for outpatient versus inpatient care. And I think we've also seen that and we've also seen discussion that we need to look at where we go forward. So, for instance, CMS is proposing in the new contract that we have a variation in the amount of medical records that are reviewed based on the provider's outcomes. So if we have a provider who has a very low rate of improper payment, we would expect to decrease as we go forward their number of records looked at. If we have a provider who has a higher rate, we would expect to increase that going forward. So CMS is looking at that. So I think what I would say is we want to collaborate with you, and I think this opportunity to share information is very good, and I look forward to be involved in continuing this sort of information exchange.
Okay. Thank